All right, well, hello everyone, and welcome to the Academy for Eating Disorders webinar entitled Recognizing and Managing Medical Emergencies in Patients with Eating Disorders with Dr. Angela Guarda. My name is Dr. Michael Spaulding Barclay, and I am your moderator today. Also with us is Bethany Blackwell, AED's Communications and Marketing Manager. If you have any technical questions or concerns about this webinar, please feel free to reach out to Bethany directly at AED headquarters via email at bblackwell@aedweb.org. That's BBLACWELL@aedweb.org, or by phone 703-234-4125 in the US, of course adding a +1 if calling from outside the US. Just a couple of housekeeping items before we get started. All participants are currently muted, with the exception of Dr. Guarda and myself. The webinar is scheduled for 60 minutes and is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience 24 hours a day, 7 days a week. In just a few minutes, Dr. Guarda will begin her presentation. She will leave some time at the end to answer questions from the audience. In order to submit a question for her during the presentation, please use the chat text box on the bottom middle of your screen, which I can read, and then I can collate questions prior to the Q&A time at the end. Dr. Guarda, let's check your volume quickly. Please say just a few words, and if a couple of the participants could let me know via the chat text function that you can hear her clearly, that will allow us to get started.
Good morning, and thank you, Michael and Bethany. It's a pleasure to be here, and I'm looking forward to talking. Could you hear me?
Now I can hear Dr. Guarda fine. But if someone that's a participant that could use the chat text function just to assure that you can hear too, that would be great.
Oh, excellent. We can hear you.
Wonderful. Thank you, everyone, for letting us know that you can hear Dr. Guarda. Now, please allow me the pleasure of introducing our speaker officially. For those who don't know her, Dr. Angela Guarda is a board-certified psychiatrist, a fellow of the Academy for Eating Disorders, and the Stephen and Jean Robinson Associate Professor of Psychiatry and Behavioral Sciences at Johns Hopkins Medicine. She has been the director of the Johns Hopkins Eating Disorders Program since 1997 and is a member of the Miller-Colson Academy of Clinical Excellence and the recipient of research grant funding in eating disorders from both the National Institutes of Health and the Klarman Family Foundation. Dr. Guarda's clinical interests include improving meal-based weight restoration outcomes for patients with anorexia nervosa and underweight ARFID, as well as medical stabilization and intensive behavioral treatment of severe eating disorders. So, without further ado, Dr. Guarda, the audience is yours.
Thank you, Michael, and welcome everyone. My talk today is going to concentrate on medical and psychiatric emergencies in patients with eating disorders. And I thought I'd start by explaining a little bit about my background. I am a psychiatrist, as Michael said, and have run the Johns Hopkins program now for over 25 years. And that is a comprehensive eating disorders program that includes medical stabilization, inpatient, partial hospital, and outpatient treatment. And because we are located in a tertiary referral academic center, we have access to all medical specialists and therefore have the ability to manage quite medically complex cases on a psychiatric unit. So it's a kind of unusual role for a psychiatrist. But as a result, I'm quite familiar with the medical management and tend to treat more severe or complex cases. I would like to start by making sure that I oh, first of all, I should clarify, I don't have any disclosures, and here are our objectives for today to really, there are three: to recognize signs and symptoms of serious complications, describe emergent medical and psychiatric management, and really some guidelines on when to hospitalize patients for medical reasons. So I would like to bring your attention, if you're not familiar with it already, to a very important and easily accessible on the web publication, the Purple Brochure or AED Guide to Medical Care of Patients with Eating Disorders. And this resource is has developed over the course of 13 years and has involved the input of many different people. It is now in its third edition and was really the brainchild of a parent who wanted physicians to recognize and refer patients with eating disorders earlier. It's I have been involved in the third edition, but really many of the names that you see here have been working on this since the beginning 13 years ago. It is available and now translated into 10 different languages, and you have the link here to access it. And if you're not familiar with it, I encourage everyone to download it and have a look through it. And if you look inside, you will see several sections. This covers a wide range of topics, ranging from diagnosis and presenting signs to assessment, criteria for admission, refeeding syndrome complications, and ongoing management. So again, please refer to that if you are not familiar with it. It has a lot more information than I will cover today. Today, I am going to concentrate on really emergencies rather than more broad diagnosis and recognition. And why are we picking this topic? Well, most of you, I'm sure, are well aware that eating disorders, and especially anorexia nervosa, but not exclusively, have high medical and psychiatric morbidity, and indeed anorexia has high mortality, as do some cases of other eating disorders. And there is not just the problem with complications, there's also frequent comorbid conditions, both medical and psychiatric, that we tend to see in our patients. And therefore, the identification of serious complications is essential to all practitioners, ranging not necessarily just physicians, but also other members of the treatment team. Because most medical consultants, frankly, have had very little training in eating disorders, perhaps just 1 or 2 lectures in med school, and therefore may have limited knowledge or experience. So if you're a dietitian or a therapist, you may actually have more knowledge about medical complications and be able to bring those to the attention of the physician on your team. Why do medical complications matter, other than the obvious reasons of morbidity? Because increasingly we think that some of them play a role in maintaining eating disordered behaviors. For instance, starvation is increasingly recognized as having a number of complications, including, for instance, GI complications that maintain the drive to restrict eating. Similarly, the more patients binge or purge, the easier it is to continue those behaviors as a result of physiological changes that are consequences of the behaviors themselves. And the other important thing to note is that most patients with eating disorders have some level of ambivalence towards treatment, or at least towards normalizing all of their eating behaviors. Therefore, frequently what brings them to treatment are these complications, these medical complications of what they are doing. And therefore, relief from symptoms is a common goal for both providers and patients, including ambivalent patients or patients who have otherwise avoided treatment may seek treatment because of complications. And therefore, recognizing these and using them motivationally to help patients engage in treatment is an important skill. And finally, there are ethical issues that arise related to this ambivalence towards treatment when patients may refuse treatment despite being critically ill. And I will try to touch on those at the end of this talk. So I'm assuming that most people on the call are familiar with the diagnostic categories as defined most recently in DSM-5. So I won't go into detail on these, but I've listed the major eating disorders here. Importantly, anorexia nervosa is a syndrome of self-starvation, and we now have BMI cutoffs that determine severity. So in general, extreme is considered a BMI of less than 15, and these are those usually most at risk, but not always. Bulimia and binge eating are characterized by binge frequency of at least once a week, and ARFID, which is a new diagnosis, involves restrictive eating patterns resulting in either weight loss or nutritional deficiency, but without the presence of the weight and shape concerns seen in anorexia. And other specified feeding or eating disorders then are a kind of catch-all category that has both clinically significant syndromes that don't meet criteria for one of the other diagnoses, or a couple of other preliminary diagnoses like purging disorder and night eating syndrome that we haven't been researched or understood as much. And importantly, this new diagnosis of atypical anorexia, which includes patients who were initially overweight, but have lost a percentage of body weight similar to what one would lose in anorexia, but are not yet underweight. And these patients, depending on their rapidity of weight loss, may have significant risk for many of the complications that we also see in anorexia nervosa, so that they may present looking normal weight. So I'm not mastering the clicking well. Okay, so what are some of the emergency presentations that we should be aware of? And these are obviously not necessarily comprehensive, but I just want to run through some of them. A frequent reason that brings patients to treatment is syncope or presyncope, fainting or dizziness, delirium or altered mental status or confused thinking, a seizure, usually from electrolyte imbalances, typically low sodium or from low glucose, an acute abdomen, which is extreme abdominal pain, or intractable vomiting, or vomiting blood or hematemesis. Sometimes fractures may bring patients into treatment. Obviously, the extreme is a cardiac arrest. Severe edema, which when it is full body edema is called anasarca. In severely underweight patients, patients do become immunocompromised and are at risk of infection or sepsis. Intoxication is always a concern when patients present in a medical crisis. It could be from a substance such as alcohol or drugs. It could also be from polypharmacy, as we'll see. And then finally, severe self-injury or suicidal symptoms or a suicide attempt. So I'm going to start by running through a case that will illustrate some of the complications that then we'll move to talk about. And this is a case of a 43-year-old who presented with extreme binge purge anorexia with multiple purging behaviors, a BMI of 14.5, a family history significant for mood and substance abuse problems, as well as binge eating in a parent. And she presented as a very extroverted, novelty-seeking temperament who was separated from her husband due to domestic abuse and problems with her eating disorder, had been on Social Security disability for the past 10 years, and had a significant substance abuse history with binge use of alcohol, intermittent abuse of benzodiazepine and opioid prescriptions, which she would have prescribed for back pain that did not have clear radiological findings. In terms of her past history and her presentation, she had had an eating disorder starting at age 14. At that time, her baseline BMI was normal, and she started off with restricting type anorexia, but by college had progressed to purging through both vomiting and laxative use daily, and was also experimenting with social binge drinking. Her BMI dropped to around 18 and stayed there for about 15 years, during which she did successfully conceive and have 2 children, but got divorced thereafter because of the eating disorder and the marital issues. She was working, however, in the service industry, but in the setting of the divorce, her weight dropped lower and fell into the critical range of a BMI of 13 to 15, where it has remained since. She has had many hospitalizations, upwards of 20, and been on trials of many antidepressants as well as a mood stabilizer, and had a trial of ECT, all at outside hospitals, and had 1 suicide attempt by benzodiazepine overdose. She arrived at our facility after loss of consciousness and admission to an ER. And at admission, her prescribed medications included lorazepam, Ambien, hydrocodone, metoclopramide, and quietapine. So she was on 2 neuroleptic medicines, because metoclopramide or Reglan is, although it's a GI med, is in the class of neuroleptics. And she was on 3 controlled substances. So despite a very, very low BMI, her admission labs were a potassium of 2.1 or hypokalemia. Sodium was also low at 120, and her glucose was low at 45. Her heart rate was bradycardic at 50 beats per minute, and she had a QT interval of 6:15, which is considered very prolonged. So the question is, what next? Well, I've already given you some of this information, but obviously the first steps emergently are to establish vital signs, including orthostatics, which means both sitting and standing pulse and blood pressure. If those differ by more than 20 points, that's considered a significant change that may be related, for instance, to dehydration. Baseline labs at admission should minimally include a complete blood count, a complete metabolic panel, phosphate, thyroid stimulating hormone, and a urine tox, an EKG, and we've kind of gone over those. Clearly, this is a patient with a history of a suicide attempt, and she's presenting with with an impaired mental status. So thinking about whether this was an overdose is important. She's on a cocktail of controlled substances that she may not be taking as prescribed and questionably shouldn't be prescribed. So she's clearly at risk for withdrawal and may be dependent on them. And finally, the list of medications she's on, given her BMI, certainly raise eyebrows for polypharmacy and her being on too much medication. So what was her hospital course? Well, her potassium was repleted by mouth, usually with 40 milliequivalents once an hour until when repeated labs to check till normal. She was started on a weight gain protocol initially at 1,200 calories per day, and it was advanced over the course of 12 days to 3,500 calories daily. She had daily labs, and finger sticks were monitored after each meal until they remained normal. She was also given intravenous dextrose half-normal saline at a slow rate to prevent edema, but with thiamine to prevent Wernicke-Korsakoff syndrome, and I will be talking about these later, and was slowly tapered off the benzodiazepines and opiates she was on while monitoring her for withdrawal using the Clinical Institute withdrawal scales for alcohol and narcotics. Initially, she refused to eat meals for several days, two days or 2.5 days, stating she intended to starve herself to death, and was told, therefore, that although she was admitted voluntarily, she would be certified by 2 physicians and was scheduled for a commitment hearing before a judge to switch her to involuntary status since she was asking to leave. During the period before the hearing, however, she was included in groups and motivational interviewing. It identified her daughter as a reason to live. She was very close to her younger daughter who had been a support and who was on the phone with her often. And the day before the commitment hearing, she, in a sense, converted, saying, okay, I want treatment, and thereafter participated well in treatment, completed all her meals, engaged in groups, and eventually, however, did leave against medical advice at a BMI of 16.5, but was encouraged to return for further treatment if she didn't do well, and did actually come back about 6 months later, and on that second admission, again, left prematurely, but was much more engaged and participatory. So I'm going to use this case to highlight some of the complications that we all should be aware of. So first off, I mentioned that mortality rates are elevated in eating disorders, and in fact are the highest for any psychiatric condition in the case of anorexia. And here you see the results of a study by Debbie Franco and colleagues that looked at close to 250 patients with anorexia over a 20-year period and examined mortality rates, which were found to be 4-fold normal, with most deaths occurring in the first 10 years, but notably, those who died tended to be older and therefore have the longest duration of illness. So our patient, who's 43, is falling into that category. Additionally, predictors of death included alcohol use, which our patient had, low BMI, which she clearly had, and poor function. And she was, after all, had a marked decline in her function over the years. She was now on disability. She actually lost custody of her children. She was living partially with her mother. So we are seeing a lot of these predictors in this case who therefore is certainly concerning for being high risk. Another study by Nielsen also points out that comorbidity with type 1 diabetes, which our patient does not have, is alarmingly associated with alarmingly high mortality rates. And that's because, as most of you are aware, patients who have diabetes and an eating disorder often are compelled to underdose their insulin in order to waste glucose in their urine, and consequently will run high glucose levels and have high risk for both DKA and long-term complications of diabetes. So I mentioned that's some of the kind of global mortality data, but it's worth also noting that mortality in anorexia is highly associated with psychiatric comorbidity. And this study, which was a Swedish register study that looked at 8,000 inpatients with anorexia over close to 40 years, found that 42% had a comorbid psychiatric diagnosis. And you see here the most common psychiatric comorbidities that we recognize in eating disorders. And of those, close to 9% died during the follow-up period that was, I think, 30 years, versus only 2.9% of those that did not have a comorbid psychiatric condition. And risk of suicide was significantly elevated. Furthermore, if we look at what comorbidities were most associated with death over time, we see here that alcohol and substance abuse are the most elevated. And it's worth noting they're also some of the most frequent. I mean, we don't often see schizophrenia, for instance, or psychotic disorders comorbid with anorexia. So there are less patients here to begin with, but there's also the highest risk with one of the most common comorbid conditions. And again, this meets our patients' history. And not suicide. So we talked a little bit about suicide, but it's worth mentioning that non-suicidal self-injury, which we recognize as common in this population, also tends to be associated with higher risk of attempted suicide, and is common in both anorexia and perhaps more so in patients with bulimia, who tend to represent, in some cases, a more multi-impulsive or personality. So I'm going to now move towards talking about medical complications. And in some ways, I think it's best to think about these as consequences of the behaviors your patient is engaging in. So some medical complications are primarily due to restricting. Some are primarily due to purging behaviors, whether by vomiting, laxatives, diuretics, or otherwise. And the combination of both, so the underweight purging patient who's severely malnourished is often at the highest risk. There also are complications that arise during refeeding. And so I will touch on these additionally, because some of these are potentially iatrogenic or caused by inappropriate management. And it's important for us to have some idea of what we know about refeeding risk. Finally, I also want to mention that some of the complications we see are going to be complications that are related to patients' misuse of medication. And that can include laxatives and diuretics as part of purging behavior, but it also can include appetite suppressants, stimulants such as amphetamines or excessive caffeine intake, and rarely we see abuse of thyroid hormone or synthroid as a way to increase metabolism and decrease weight. So these are also things to bear in mind, certainly when taking a history, and to ask about quantity on. So what organ systems are affected by medical complications? The simple answer is all. And I will concentrate today on the more serious ones, but it's important to realize that these really are disorders that affect the whole body and that can have very serious complications. So let's start with kind of the main ones to be aware of. One big area is cardiovascular complications, because death is frequently by cardiac arrhythmia in eating disorders. And arrhythmias occur as a complication frequently of electrolyte imbalances, but they are more common in severe bradycardia, which is associated with starvation, and a heart rate of less than 40 beats per minute is certainly not very concerning and would warrant admission. Prolonged QT, and remember our patient had a QT corrected of 600 and I think 15, so way over this 450 limit, is associated with a lethal heart rhythm called torsade de pointe and sudden cardiac arrest. And in our case was probably complicated by the medication regimen the patient was taking. She was on at least 3 agents that prolong QT, which is something to be aware of when prescribing, for instance, neuroleptics for this population. Make sure they have a normal QT and think twice if they're severely underweight. Orthostatic hypotension can lead, obviously, to syncope, and as a result of chronic starvation, you can see a starvation-related cardiomyopathy that's atrophic from atrophy or toxic. Toxic cardiomyopathies related to eating disorders usually result from abuse of Ipecac. Now, Ipecac is not on the market or easily available anymore, but if you are treating a patient who is in their 40s or 50s and has had chronic anorexia, it is worth asking about, because some patients may have abused this medication in the past, and its metabolites collect in cardiac muscle and can be toxic over time. Furthermore, the older a patient is, of course, the more insults her heart has sustained as a result of the continued chronic eating disorder. And you can develop what's called a dilated cardiomyopathy that results in congestive heart failure. Congestive heart failure can also be a complication of severe edema. And here we're talking not just about edema in the legs, but really more like full body edema that extends up into the trunk. And if a patient is, well, this is just to show you the QT interval. For those of you who aren't familiar with an EKG, is really a portion of the heartbeat, and the corrected QT is corrected for heart rate. In a patient that's chronic and has been ill for a very long time and is very malnourished, doing an echocardiogram at the start of treatment makes sense to ensure they do not have a cardiomyopathy. The other reason for that is that as they gain weight and may develop edema, you're going to tax their heart, and you want to be sure that you are managing that conservatively. It's also worth mentioning, besides Ipecac, that some older patients may have taken phentermine and fenfluramine especially, which is associated with valvular injuries. And so occasionally there is a patient with an eating disorder who's older who may have complications of chronic past fenfluramine use. Fenfluramine was marketed as a diet medication back in, I think, the 70s or 80s, the 80s, I think. Okay, besides cardiovascular deaths, the other medical, probably most common risk is hypoglycemia or low glucose. And of course, low glucose, we all know that when we're hungry, we tend to be cranky. And certainly this contributes to probably a mood impairment that we see in our patients when they're very starved. Furthermore, patients who are starved have low glycogen stores. What's glycogen? It's really a storage form of glucose in the liver that the liver releases to keep the glucose in our blood stable between meals. And both due to low glycogen stores, to altered insulin sensitivity in anorexia, and delayed gastric emptying, glucose is not well controlled and tends to fall below normal easily. And this is what's worth noting here, is that it appears that when you start to refeed patients, glucose drops after meals. So although in diabetes, we usually check glucose before meals, in this population during refeeding, lowest glucose often occurs postprandially after meals, and is when we would recommend checking finger sticks. And at the extreme, hypoglycemia can lead to seizures or coma, and obviously death. So I'm going to kind of run through for you now some of the electrolyte abnormalities that you should be most aware of, because they are often underlying cardiac arrhythmias or death in eating disorders. And the big one is really hypokalemia or low potassium, which can result from purging behavior. And usually patients need to be vomiting at least once a day to see low potassium, but you see low bicarbonate often before you see low potassium on the labs of patients who vomit. You also tend to see low chloride in patients who are vomiting because they are vomiting hydrochloric acid in their stomach, and therefore their chloride will fall. In patients who abuse laxatives, you are more likely to see an acidosis than an alkalosis. I'm sorry, in patients, yes, that's correct. You're more likely to see an acidosis because they lose bicarb through their stool and have proportionally more chloride. So low sodium is always something to be aware of, as it does increase seizure likelihood, and it is usually a function of drinking excessive water, a behavior that many patients have, both to feel full, sometimes to make weight, or because of an idea that it is healthier or cleansing. And then low magnesium and calcium are less likely, but also possible complications. And some patients present with low phosphate in the starved state. However, hypophosphatemia is also a complication potentially of refeeding. And I'll talk about that further in a little bit. And in general, when you encounter a patient with electrolyte abnormalities, it's important to recognize that oral repletion is safest. They don't usually need IV, except in extreme cases when they really should be in an ICU. But the best thing is to provide oral repletion when that is possible. Okay, I want to turn now to talk about the GI tract, because GI problems are normative in patients with eating disorders. In this study by Boyd's group, they looked at about 100 consecutive admissions to an inpatient unit, and 98% complained of, or met criteria for what we call a functional gastrointestinal disorder. Functional disorder means there isn't a structural problem like a blockage, but the GI motility is abnormal. Things don't work in synchrony or move through the GI tract normally. And the most common diagnoses that we encounter in our population are irritable bowel syndrome, complaints of bloating, functional abdominal bloating, functional constipation, and heartburn or gastroesophageal reflux. Well, certainly you can see a wide range, and many patients have more than one of these. So I'm just going to take a little aside. This isn't a life-threatening complication, but it can be a motivational complication for patients to enter treatment, so it's a good one to be aware of. Vomiting is associated with enamel erosion because of stomach acid, and you often see this kind of arch-like erosion of the incisors and a erosion of the lingual, the inside surface of the teeth that exposes the underlying dentine. So you can see here that the enamel is this white coating, and that inside, this is the inside of the tooth that's been exposed. And sometimes one important thing to tell your patients if they do vomit is not to brush their teeth afterwards, because the acid softens the enamel and it increases the risk of abrading it. The other common presenting feature that you may see in patients is what we call bilateral parotid enlargement. The parotid gland is the major salivary gland, and it hypertrophies with frequent vomiting. And when patients stop vomiting, this may actually get worse before it gets better. And that's an important thing to tell patients. Heat packs will help with the pain, but it does resolve. It does sometimes take months or years for the gland to shrink, however. Now, moving down the GI tract, the esophagus can be affected by vomiting in a number of different ways. You can see tears in the esophagus called Mallory-Weiss tears. These are usually what causes blood in vomit, which is certainly a serious indication of a need to admit a patient. But frequent vomiting results often in reflux and in what's called Barrett's esophagus. This is looking down the esophagus at healthy tissue at the juncture with the stomach. Here you see damage from prolonged reflux, and here you see Barrett's esophagus, which is a precancerous change in the esophagus in this region that is frequent in patients who vomit. And finally, a very rare complication, and this one really I've never seen, for instance, is Borhave syndrome, which is actually a rupture of the esophagus that's extremely life-threatening and emergent, but again, rather very uncommon, luckily. So I mentioned functional GI disorders being common and that this often is associated with motility. What is the evidence for motility impairments in eating disorders? Well, here you have comparison of gastric emptying and intestinal transit times in healthy controls and patients with restricting or purging anorexia. And you can see that the anorexia is associated with delayed gastric emptying. And in this other study, which looked at whole gut transit, you again see the controls have faster whole gut transit than both patients with anorexia or patients with bulimia. Moving down to the stomach and the liver and pancreas, gastric ulcers are not uncommonly associated with chronic starvation. You can also see a starvation transaminitis or elevation of the liver enzymes. And this can be exacerbated temporarily by refeeding. It is usually asymptomatic. You can also see an inflammation, but it reflects damage, liver damage, and release of these enzymes from the liver cells. Pancreatitis is reflected in increased amylase and lipase levels, sometimes associated with vomiting and extreme abdominal pain. And another very rare but extremely serious complication is acute gastric dilatation, which usually is most common in severely malnourished patients with anorexia who binge. And this is an example of gastric dilatation. And what you see here is this whole thing is the patient's stomach. And actually, in this case report, she had binged on mac and cheese, which you can actually see in this illustration. This requires emergent nasogastric decompression or surgery, but again, is a very rare but very serious complication that would present with nausea, crippling abdominal pain, and often unstable vitals and shock. Okay, some of you are aware that in severely malnourished anorexia, there is a concern for something called superior mesenteric artery syndrome. What is this? Well, this is the aorta, or the main blood vessel that lies along the spine, and it has an artery that comes off the superior mesenteric artery that feeds the gut. And running under it is the duodenum, the beginning of the small intestine, and it's coming towards us. This is a cross section. And in starvation, the angle of the SMA may become more acute because there's loss of this fat pad here. So sometimes patients who have radiological findings consistent with this narrowing of this angle and present with acute abdominal pain, anorexia, and nausea are emergently operated on with what's called a duodenojejunectomy, which bypasses the gut from here to lower down, so this piece is no longer needed. However, the evidence suggests that in most cases of anorexia, certainly in this case, this report of published case series, the majority of patients who have these radiological findings can be managed conservatively, and the symptoms resolve with refeeding alone, meaning their GI pain resolves without surgery. So an attempt at normal feeds is indicated rather than operating on someone who is immunocompromised and is to some extent a greater surgical risk. It's also unclear if it's always successful. We really don't have good follow-up data. Other intestinal complications include ileus. What's ileus? It's kind of a paralysis of the large intestine here, of the small intestine, sorry. Here you see the small intestine filled with gas because nothing's moving, and stool. And what this can be a complication of starvation. It usually resolves with bowel rest for a day or two. Volvulus is a life-threatening complication where there is a torsion or a twisting of the intestine, and that does require surgical intervention. Rectal prolapse is common in laxative-abusing patients. And what happens in rectal prolapse is that a piece of the rectum gets extruded from the anus, and it can be manually reinserted in most cases by the patient, but it sometimes can be fixed using physical therapy exercises of the pelvic floor, but it may require surgery. But in order for the pelvic floor to heal, patients have to be at a reasonable BMI before the surgery, because the pelvic floor muscles, if they're wasted, won't heal, and that operating on patients at low BMIs for this complication is not indicated. This is an old study, but an interesting one, because what it shows is that GI complaints in patients with anorexia tend to decrease with refeeding alone. What you see here are patients with anorexia at admission and at discharge from a behavioral meal-based program. Actually, this study was done here at Hopkins before I trained here. And you can see a number of different GI complaints on the bottom, and clearly an improvement with weight restoration. Of note, there is not an improvement necessarily with GI meds alone. Osteoporosis is a common complication of anorexia and of starvation. There is a thinning of the microarchitecture of bone, and the fractures we are most concerned about, because arm fractures will heal, are vertebral crush fractures like this one, which cause curvature of the spine and chronic pain, or hip fractures. And you can see here from this study that the expected versus observed rates of fracture in anorexia are significantly elevated. And we do not have good ways to treat or reverse osteoporosis in anorexia. Anorexia is both a low estrogen and a high cortisol state, which may be why estrogen alone does not seem that effective, although there is an early study that shows that perhaps transdermal estrogen replacement, at least in adolescents, may be promising in preventing or altering bone loss in adolescents. Kidneys can be involved. It's less common, but you can see problems in creatinine clearance, worse in purgers than in restrictors. They tend to improve with refeeding, but there are occasional case reports of renal failure, and this may be a result of chronic low potassium and intravascular volume depletion. I mentioned that patients of very low weights are immunocompromised, and they are at risk for opportunistic infections that we usually only see, for instance, in patients with advanced AIDS or with terminal cancer. But what you see here is bone marrow architecture in a healthy individual and in a patient with severe anorexia. And you can see that there is this fatty infiltrate of the bone marrow and there's less cells. So there are less stem cells producing white blood cells and red cells, which accounts for the anemia that is associated with severe malnutrition. And here is a radiograph of a patient with Mycobacterium zolgai, a mycobacterial infection that we never see in healthy individuals, but that has been reported in a number of cases of anorexia nervosa, as have other similar opportunistic infections. So this is an important thing to be aware of, the increased risk of infection. Okay, I said I'd touch on refeeding syndrome. which is a constellation of potentially life-threatening changes that result from rapid oral, enteral, meaning NG tube, or parenteral, meaning IV, intravenous feeding. And the hallmark symptom of refeeding syndrome is low phosphate or hypophosphatemia. As I mentioned, you can also see drops in glucose postprandially after meals that are concerning and that need to be corrected. And there is often the development of lower extremity edema, but it can rise and become full body edema. Typically, edema of this nature is what's called pitting. You can press on the tissue and it will leave an indentation, a temporary indentation. These are finger marks. Ileus, due to edema of the gut, can occur. Congestive heart failure due to fluid overload and third spacing can be a complication. And you can see neurological complications due to cerebral edema too. Importantly, recent evidence supports the fact that BMI at admission is a bigger determinant of hypophosphatemia than rate of weight gain, which used to be thought to be highly correlated with risk of developing low phosphate, but it now looks as though so long as patients are refed and closely monitored medically, we are able to accelerate early rate of weight gain and produce better weight restoration outcomes than we thought, as long as we follow phosphate and replete it appropriately orally. Okay, a couple of important complications that are related to refeeding potentially to know about. One of them is Wernickesencephalopathy. This is really important. If a patient is very malnourished, BMI of 15 or less, they must get thiamine or vitamin B1 before they start eating. And that is because if they don't, there is a risk that they will demyelinate part of their brain. And Wernicke's presents with a classic triad of abnormal eye movements or paralysis of the eye, partial paralysis of eye movements, ataxia or wide-based and unstable gait, and confusion. However, most patients don't have all three. And what you see is this bilateral symmetric demyelination of the mammillary bodies, as well as edema causing this fuzzy appearance to the brain. And importantly, this complication is more common in patients who underwent gastric bypass and have had rapid weight loss with potential development of an eating disorder. And we are increasingly seeing bariatric cases with eating disorders. So these cases especially must get thiamine repleted at least 100 milligrams 4 times daily at the start of refeeding. And that may be true for atypical anorexia with rapid weight loss too. We just don't have data right now. A potential complication of rapid correction of low sodium is something called central pontine myelinolysis. This is the pons area of the brain, and it results in confusion, mumbled or dysarthric speech, problems swallowing or dysphagia, progressing to potential death. And it's due to trying to correct sodium intravenously too fast. So sodium, if it's low, potentially due to excessive water intake, should be corrected slowly with water restriction. And severe hypoglycemia can also increase risk for this. So to avoid refeeding syndrome, in summary, you need to make sure you administer adequate thiamine, be aware of glucose dropping after meals. If you administer intravenous fluids, it's a good idea to include some glucose to try to stabilize glucose, but do it slow or it'll third space and cause edema. You want to manage edema conservatively with leg elevation and tell patients to put their legs up so that they're at heart level when possible. Sometimes compression stockings can also be helpful. Replace electrolytes orally whenever possible. And be aware that you can see refeeding syndrome at any weight following extreme and rapid weight loss. So the rate of weight loss is related to risk of these complications. So I said we'd touch on level of care, and there are a number of different treatment guidelines that address determining level of care and when to admit patients to a hospital, for instance, or a residential treatment. And three of probably the three most established ones are the APAs, the European NICE guidelines, and the Royal Australian and New Zealand College of Psychiatrists one. So I refer you to these if you want more detail. Of note, although they overlap, they aren't all identical, and part of that has to do with different systems of care, as well as the fact that we don't have, that this is kind of in some ways a clinical judgment, and there isn't an exact formula for when patients should be stepped up. But in general, the guidelines tend to agree that medical instability, such as markedly, significantly abnormal labs, vitals, or severe presenting signs and symptoms, rapid weight loss or rapid decline in function, very low BMI, longer illness duration, and past treatment are relevant to establishing if a patient should move to higher level of care, in the sense that a patient may present at a very low BMI, having never been treated, and may actually respond to outpatient treatment. Whereas a patient like the one we talked about earlier, who has failed multiple treatments, is unlikely to do well in an outpatient setting, and when in crisis will need at least admission for medical stabilization and partial refeeding. Assessing psychiatric or medical comorbidity should weigh into the decision, as should risk of suicide and as I mentioned, past treatment failure. In terms of higher levels of care, there are a number of stages and settings to treatment, and they depend on the patient and the patient's history in terms of which may be more appropriate. The typical course for adolescents currently is, if they're medically unstable, brief inpatient stabilization, often on an adolescent unit, followed by outpatient, typically family-based treatment, unless they've already failed that. In the case, and the other very frequent model, at least in the US, is inpatient medical stabilization and then transition to a residential behavioral program and then outpatient. This is kind of the model that we have at Hopkins, really brief medical stabilization on a behavioral unit, followed by a briefer, more rapid meal-based refeeding than perhaps you would see in a residential program. Transition to partial hospital with a focus on generalizing normal eating behavior to activities outside the hospital, and then transition to outpatient. So it really can vary depending the right fit for the right patient. How do we measure progress in treatment? If a patient is underweight, we know that weight restoration in anorexia is the best predictor of outcome. So certainly restoring weight is key to a normal BMI, typically 20 or higher. Normalizing eating and exercise and weight control behaviors, treating any comorbid psychiatric or medical conditions, paying attention to functional status, especially for chronically ill patients, thinking about how to engage them again in some meaningful activities outside the hospital, work, volunteering, school, and realizing that eating disorder cognitions, dissatisfaction with weight and shape, are likely to be the last symptoms to resolve in recovery from anorexia nervosa, and probably will not resolve, although they are likely to improve by time of discharge from higher level of care. And when we started, I mentioned kind of the challenge of ambivalence towards treatment, which can be kind of a cardinal characteristic of anorexia nervosa, because this is a motivated behavior in the behavioral disorder, in the sense that patients at one level want to continue doing what they do, even though they have a realization that it is causing them a lot of physical, psychological, and often social consequences. So, we need to look at treatment avoidance as a symptom of the disorder, and recognize that normalizing weight or eating feel threatening and anxiety provoking. and that patients, in a sense, would prefer to talk about often than to change their behavior. They're more comfortable doing that. However, we know that in order to get well, because this is a motivated behavioral condition, we need to help patients change what they do, not just understand what may have led to developing an eating disorder. Just a word about capacity to refuse treatment. Patients with anorexia are rarely grossly incompetent, and they are not usually suicidal or psychotic. So they have good reasoning in most areas and may provide what seem like superficially rational explanations for their behaviors. However, although their cognitive reasoning appears intact, there appears to be an impairment in emotional aspects of decision-making, and especially appreciating the consequences of the disorder. So they may be able to list the pros and cons of treatment or the complications, but really not feel that those consequences apply to themselves. So competence, which is a legal term, tends to be, is defined as task specific, and it implies the cognitive capacity, a medical term, to make an informed decision. And the problem in life-threatening anorexia is again that patients have difficulty appreciating the consequences of the choice, for instance, to refuse treatment, and have difficulty making a free decision about entering treatment, even if they understand the risks and benefits. And we also have evidence to support that this lack of capacity regarding consenting to treatment is state dependent and tends to reverse with weight restoration and progress in treatment. In one study by Watson and Anderson, weight restored but involuntarily treated patients tended to retrospectively view their treatment as justified. And we have shown that close to half of patients who were admitted to an inpatient unit under what they felt was pressure from others or perceived coercion converted within 2 weeks to acknowledging, well, I do need to be here and I do want to stay voluntarily. So change in motivation tends to increase with change in behavior. Finally, a word about involuntary treatment. It remains controversial and still employed by few centers. However, it is worth noting that the most recent data indicates that there is not a clear difference in mortality long-term between patients who are treated involuntarily by court order and those who are voluntary admissions. And there is no real data supporting harm from involuntary treatment, which is often met with gratitude on the behalf of patients over time. So that's not to say that it is always warranted, and certainly infringing on patients' autonomy through involuntary treatment needs to be weighed against the benefit of the likely benefit of the treatment. It's only indicated if the outcome is expected to be better than the risk. So here is a second case that I'm going to close with, where the outcome, if you remember in our first case, that was a chronic patient with 20 plus admissions. She left early from both her admissions with us, as she had from every other admission. We did not try to certify her before her attempt to leave because she really did meet criteria for severe and enduring and had failed multiple treatments, and the likelihood of us being able to succeed this time did not seem to warrant certification. But this is a slightly different case. This was a 26-year-old, again, with what would qualify as severe and enduring anorexia, 13-year history. She was, however, still working when she was admitted, and she'd only had one admission as opposed to 20 or 30 to a behavioral program, and had left before being fully weight restored. She too had heavy alcohol abuse, but had recently stopped drinking in the past 6 months. The reason she was admitted is she had marked abdominal distension, had had recent weight gain, edema, and had low potassium, magnesium, and phosphate, and elevated amylase and lipase. She was on the medical floor at Hopkins and developed life-threatening hematemesis, was vomiting blood, requiring an emergency endoscopy, clipping of an ulcer, and transfusion with ICU stabilization, after which she was offered transfer to our unit, which she refused. However, since her parents supported involuntary admission and she was judged not able to make not having the capacity to make a rational decision, she was transferred as an involuntary patient on certificates to our program. Like with our other patient, her electrolytes were repleted and followed closely, as was her glucose. Her edema was managed with compression stockings and leg elevation and low-dose aldosterone, a potassium-sparing diuretic, and resolved within several weeks, though. It took quite a long time. She was initiated on a weight gain diet and attended groups, was in some family-based treatment too. Even though she was an adult, she was living with her parents. She completed the program. It did take 3 months, but she was discharged weight restored, and she has maintained her weight and is doing well a year after discharge and is fully employed. So this is a very different outcome for what would also be seen as a chronic and severe case, but one that really did not have a chronic history of treatment, had largely avoided treatment and did well. So then to summarize finally, for those of you kind of in the outpatient world who are just wondering what should I recommend if you're worried your patient is unstable, the basic diagnostic tests that should be considered in any patient with an eating disorder include the following: vital signs, complete blood count, comprehensive metabolic panel, thyroid function, because thyroid function can be both high or low, but in eating disorders, but contributes to appetite and mood. Urine tox, because remember, some patients are taking too much of something or are sometimes taking street drugs, and an EKG. So finally, and I'm sorry I've run over by a little bit, eating disorders are associated with high morbidity and mortality. We all need to be aware of both serious medical and psychiatric morbidity and best management for these cases, and appreciating some of the ethical problems that arise from the ambivalence towards treatment that can be central to the phenomenology, especially of anorexia, but to some extent of most eating disorders, is important to caring for these patients, especially the most critically ill ones. So that brings me to the end of my presentation, and I'm happy to open the discussion to any questions.
Thank you, Dr. Guarda, for that excellent presentation. I'm willing to hang out for just a couple of minutes here to see if any of the panelists want to submit a specific question via the chat function. And if not, I have a couple of questions myself that I've heard from people before when at talks like this that might be helpful. But let's wait just a minute or so to see if people from the audience would like to submit a question. And again, you can do that by typing it into the chat text box function.
Looks like we have a question here. Michael,
I do see that one. That question is a logistical question of how can we get the slides. The whole presentation actually is going to be available on the AED website, aedweb.org. That's aedweb.org. And that's available for members to download at any time, 24 hours a day, 7 days a week. I'm not sure if it'll be up today, but it'll be up very soon. I have a question for you, Dr. Guarda. From a therapist or dietitian standpoint, does the AED Guide to Medical Care that you mentioned have information for primary care doctors who may not be as familiar with eating disorders as the therapist and dietitian in the outpatient may in fact be, on what labs or procedures they should be ordering to evaluate for these medical emergencies?
Yes, the guide is really, it has a lot of information. It has information on what labs, what tests are indicated, and on what kinds of abnormalities are most concerning. So it is an extremely useful resource, which I, again, would recommend that everyone consult. Now, I didn't close with that, so if you joined us late, please, when you download the slides, look at one of the early slides in which I summarized information and a link for the AED medical guide to the treatment of eating disorders, which, as Michael points out, is a very comprehensive introduction to what any healthcare provider should know in terms of both screening, detection, and management of complications, as well as reasons to admit patients to a higher level of care.
Thank you, Dr. Guarda. And then just drawing on your vast wealth of knowledge in treating these patients, for less severely ill patients, maybe more routinely seen in the outpatient setting, particularly those struggling with purging via vomiting, is there a well-known correlated number of purges per day or number of purges per week that is accurately predictive of electrolyte abnormalities? And if not, do you have any personal recommendations for the potential of kind of helping therapists or dietitians out there, encouraging primary care providers on how frequently maybe they should be checking labs in one of their patients who is a fairly routine purger?
The data that I'm aware of, there is one study that showed that purging once a day or more is kind of a cutoff, but realize that some patients purge multiple times a day and have normal labs, and some purge less than once a day and have abnormal labs, because it also depends on the severity of the purging behavior and possibly on individual differences, as well as on the veracity or reliability of the patient's report. So I think that I hesitate to give any magic number, but I would say that you certainly should be concerned if your patient is purging once a day or more. With laxatives, if they are using laxative once a day or more, and the amount they may be using, because it's not uncommon for patients to be using 15 to 30 Dulcolax a day. That kind of use is obviously much more concerning than one dose twice a week. So there isn't an easy answer. In terms of how frequently should labs be checked, I think in any patient who purges, perhaps one could argue in any patient with an eating disorder, baseline labs are important. If they are normal, in somebody who purges, I would repeat them at least once or twice a few weeks apart. If they remain normal, I guess I would only repeat them if the purging escalates or their weight loss increases. But I don't think this is kind of a clinical judgment. There is no clear standard, and it really depends on the case.
Wonderful. Thank you for sharing your clinical expertise, Dr. Guarda. There was one more question that was submitted by a participant about which inpatient programs actually are able to take patients to court for weight restoration. You know, I don't know if there's a specific listing, Dr. Guarda, that you're aware of. Obviously, there are programs that do that. Are you aware of an accurate list that's kept anywhere of those programs?
No, I think it's really something that varies by program, and I would not feel confident naming any particular program, because I'm aware there are more than there used to be. But again, it really depends on the case. We don't want to treat patients against their will. It is only a life-saving measure that we would consider if the benefit outweighs the cost. Furthermore, there are a lot of legal limitations. For instance, most commitment rules are in the US are state dependent. So they may vary from state to state. Another thing that one sometimes hears about is the use of legal guardianship. Again, that can be fraught with problems too when the parents obtain legal guardianship, because that really puts them in an adversarial position with the child when they're often meant to be the child's main support. So, you know, and finally, in terms of involuntary treatment, you cannot, at least in the state I'm in the state of Maryland, you cannot transfer a patient involuntarily across state lines. And I think that probably is true nationally in the US, although I'm not certain. So it isn't easy to admit someone involuntarily out of state.
Thank you for that response, Dr. Guarda. So I guess the take-home point would be we're kind of stuck having to contact each program and specifically ask them, particularly those within the state in which your patient resides.
I
think that wraps it up. Oh, excuse me, go ahead.
No, I was just saying I was agreeing with you, yes.
Thank you. I think that will wrap it up. Again, Dr. Guarda, thank you for your time and expertise and sharing that with the AED community available today, as well as for future generations of providers, as it will be available on the website. Just a reminder for the rest of you on the call still, the next AED webinar is scheduled for September 6th at 12 p.m. Eastern Standard Time. Of course, you can find out more about this upcoming webinar as well as all future webinars by visiting aedweb.org and then clicking on the Events tab. Thank you so much for participating, and everyone enjoy the rest of the day, and we'll call that a wrap.
Thank you, Michael, and goodbye, everyone.
Goodbye, all.